Okay, good evening. My name is Nina Hunter, and I'm the Public Policy Co-Chair of the National Coalition of 100 Black Women, Metropolitan Baton Rouge Chapter. Thank you for joining us tonight for our Maternal Health Summit. It's entitled Empowering Our Moms. And we are most proud to be having this consequential conversation during National Black Maternal Health Week. Our conversation is going to include a keynote address, and then we're going to open up into a dynamic panel discussion with local advocates and local healthcare professionals. So let's get to it. To formally welcome you, I'm going to formally welcome you and to introduce our keynote speaker, I'm going to yield to our chapter president, none other than President Courtney Hunt.
Good evening, everyone. On behalf of the National Coalition of 100 Black Women, Metropolitan Baton Rouge Chapter, I want to welcome you to this very important and necessary conversation, our Black Maternal Health Summit. Black women are 3 times more likely to die from pregnancy-related complications than white women. And this is not because we are less educated or less committed to our health. It is because the system has too often failed to see us, hear us, and believe us. Tonight, we are here to change that narrative. As an organization committed to advocacy and equity, we believe that every Black woman deserves to experience pregnancy, birth, and motherhood safely and with dignity. That means raising awareness, holding systems accountable, and equipping women with the knowledge and support they need to advocate for themselves. We are especially honored to welcome Judge Glenda Hatchett, whose personal story fuels her advocacy. Her courage and voice are exactly what this moment needs. Thank you for being here tonight. Let's listen, let's learn, and let's keep fighting for our mothers, our daughters, and ourselves. I also have the privilege of introducing Judge Hatchett. Judge Hatchett is a nationally acclaimed attorney, judge, and advocate with over 4 decades of legal and leadership experience. She currently serves as of counsel at Stewart Miller Simmons in Atlanta, handling high-profile cases nationwide, including wrongful death, police misconduct, and maternal mortality. A trailblazer in the legal field, Hatchett was the first Black federal clerk in Georgia's Northern District and later became Georgia's first Black chief judge of a state court, where she led one of the country's largest juvenile court systems and launched a nationally recognized reform initiative. Early in her career, she held senior legal and public relations roles at Delta Airlines, making her the company's highest ranking woman of color. Worldwide, I might add. In the corporate world, she served on the boards of Fortune 500 companies, including HCA, The Gap Inc., and ServiceMaster, playing key roles in ethics oversight and major corporate negotiations. Hatchett in landmark cases such as the wrongful death of Bobby Christina Brown and Philando Castile, the latter of which led to the first indictment of a police officer for a civilian death in Minnesota's history. She also founded Hatchett Consulting Group, advising on crisis management and legal strategy. A respected television judge personality, Hatchett presided over the long-running Judge Hatchett Show and currently stars in The Verdict with Judge Hatchett. She is also a best-selling author and sought-after national speaker. Her service and leadership have earned her numerous awards, including the Emory Medal and the NAACP Thurgood Marshall Award. And I added this. Judge Hatchett was inducted as an honorary member of the National Coalition of 100 Black Women in October 2023 at our Philadelphia Biennial. So we want to welcome our honorary member. We are excited to have you here, and we look forward to the conversation tonight. Thank you, Judge Hatchett.
Thank you very, very much. And really, I am so honored. Thank you, President Hunt, and to all the members of the coalition in Baton Rouge. I sincerely want to thank you for this conversation tonight. And I'm not going to think of it as a speech or a keynote, but rather a conversation with the sisterhood on what is a critical issue facing us as Black women in this nation. And so thank you for this opportunity and including me in this program tonight. I'm going to be transparent. I'm going to be very candid. I am going to tell you, and I'm going to frame this conversation this evening with my story. And I know that you all know, but I want to give you the backstory of really what happened on April 12th, literally 9 years ago, 2016. Kira Dixon Johnson walked in to Cedars-Sinai Hospital in Los Angeles. She was 39 years old. She was perfectly healthy. She was beautiful inside and out. She literally spoke 5 languages fluently. At one time, she had owned not 1, not 2, but as many as 12 schools in China that she developed open to teach English in China. She was obviously fluent in Mandarin. I would hear her negotiating contracts in the middle of the night in Mandarin. She was a race car driver. She had a pilot's license. She was a scuba diver. She was a marathon runner. I mean, she was it. But very importantly, she was a loving mother. I always refer to Kira as my daughter, although she was technically married to my son. We all walked into Cedars-Sinai and never, ever expected that she would not walk out. She doesn't fit what people kind of try to develop these stereotypes. Well, she didn't get proper care. She wasn't diligent about prenatal care. Her diet wasn't good. She didn't have health insurance. None of that was true. She was meticulous about her appointments. She was very serious about all of her prenatal care, all of her appointments. And they let her die. They let her die. And there's no other way to say it other than they butchered her and they let her bleed to death. Langston was born at 2:22 in the afternoon of April 12th. At 6 o'clock, they ordered a CT scan, stat, which we all know means immediately, and it never happened. I carried a lot of guilt, frankly. I went home with the 19-month-old because they told me that she would be fine, that they may have nicked her bladder. They'd go in, it'll be a 15-minute fix, everything would be fine. I would have never left that hospital. I would have called everybody I knew, Valerie Montgomery Rice, president of Morehouse School of Medicine, and my dear friend said, Glenda, why didn't you call me? And I'm like, if I had even begun to understand she was at risk, certainly I would have not left that hospital and I would have talked to everybody possible. My son was diligent and kept saying, when are they going to take her up? They literally told him she was not a priority. At that point, I wasn't there, so I didn't hear that. So now fast forward, my son calls me, and I'll begin to abbreviate this because we've got to go on to some discussion about where we are now and what needs to happen. But I just want to frame this conversation tonight with her story. And so my son calls me and says, Mom, they're taking her into the OR. And I'm thinking, okay, we're going to get this fixed and she's going to be fine. And about 2 o'clock, he called me to say that things had gone terribly wrong and hung up. And then the door opens a little bit after 4 a.m. I kept trying to call back. I couldn't get him. I couldn't get her, anybody in the family was there. I couldn't get anybody on the phone. And I was home with a 19-month-old. The door opens shortly after 4 a.m. And I hear all of this crying and wailing. And my son said to me, "Mom, she's gone." And I'm like, how could that be? It was like, I couldn't even begin to even process that. And he turned around and said, "Where are you going?" He says, "Mom, I'm going back to the hospital to be with our son." And so there was her mother, her brother, her aunt, who was like a second mother to her, and a cousin who was really like her sister, and just crying. And I just was like, my God, how are we here? Fast forward, we demanded a meeting with all the officials at Cedars-Sinai. And much to my surprise, the head of the OBGYN department said she shouldn't have died. Of course, the lawyer sitting at the other end of the table, I'm sure she was wishing that she hadn't said that, but that's what she said. Had we gotten her back to the OR at 6 o'clock, when we knew there was a problem, when we knew there was blood in the catheter, when we knew our vitals weren't the way they should be, she would be alive. Everybody's looked at Kira's medical records, have all said they don't know how she lived as long as she lived. And I think it was her sheer determination. The nurse called me, who was in the OR, later, some months later called me, who was in the OR that night, and she said, "Judge," the last thing she said before they put her under was, "I have to get back to my babies." Those were her last words that she ever uttered in this. And so the fight had to begin. And Charles, with an enormous amount of strength, stood in the Martin Luther King Chapel at Morehouse College. Morehouse was so wonderful to open the chapel for us, for her services. And he stood there with a newborn in one arm and a 19-month-old in the other arm. And he said, "We must turn our pain into purpose." And that has been the marching orders. That has been our mantra. That has been what we're doing. That is what we're trying to do. And so that's what for Kira, the number 4, KIRA, the number 4 moms.com, and that foundation has been about. I will tell you that the doctor who butchered her is still practicing medicine in California. It is obscene. There were 6 cases before the medical board the day that Kira's case went up. She was the only fatality, but there were 5 other women whose cases were before the board, but yet and still, he did not lose his medical license. To this day, I think is a travesty in the situation. Why do we fight? And why are we having the conversations that we're having tonight? I want to tell you one other story that helps frame this. Charles said, "Mom, I can't leave without her remains." And I'm like, "We're not leaving. We're all coming back to Atlanta." He was saying he was going to stay in California. I said, "You can't stay in California with a newborn baby and a 19-month-old. And so they moved back. I brought them. We all came back from Los Angeles. I, of course, was out there. I live in Atlanta. Was out there for Langston's birth, and we came back. And we didn't do anything publicly for the first year because, I'm the mama hen here, and I just had to gather them, and we had to just hold close. But after that first year, Mother's Day, April was the first anniversary of her death. She died, of course, in 2016. Until 2017, on Mother's Day, we went public with Kira's story to sound the alarm. And if I did not know of the horrible statistics, President Hunt, that you have just shared in your opening, then that meant that a lot of people did not know. I did not know about these disparities. And what you've seen in these last 9 years is a heightened consciousness, heightened awareness a lot of people taking this on, talking about it, like the coalition has really been deeply involved in that, and for which I am and will be forever grateful. So let's talk about where we are now. Let's talk about the fact that there was a study that came out literally 2 days ago in the National Journal of Medical Association that says that there was a 5-year piece ending in their study, ending in 2022, that said that the numbers were getting a lot worse. We also know that COVID had a major impact on these numbers because of women not being able to get where they needed to go all the time, sometimes being isolated. But what I am here to tell you tonight is that, and these are not my numbers, this is not my son's numbers, this is not their foundation's number. This is what research tells us. 84% of maternal deaths in this nation are preventable. 84% of these women should not have died. And I want to put a pin right there because I'm coming back to that, because I want to also talk about what is happening in Washington with the conversation about Medicaid and those cuts. And I was careful to make a lot of notes in anticipating that we would have this conversation tonight. And I did not know that 41% of all children born in the US are covered by Medicaid benefits. And if Washington is successful in cutting these benefits, we are going to see damaging results that are beyond catastrophic. And I am not an alarmist, but I am sounding the alarm on this issue. We know that, I live in a state in Georgia where we are always hovering at the bottom. California has been doing a much better job. And what they have said in this latest report that came out in the journal 2 days ago was saying that if the nation had the same results that California has had, then we would have had more than 2,000 fewer deaths. Now think about that. And so we know that we can get some of this right in some places of the nation. Why can't we get it right everywhere? Kira would have had a better chance of surviving had she been born in the bush. This nation, with all of its wealth, ranks at the very bottom of all industrialized nations in this world. And when we talk about the disparity among Black women, I don't want any women to die. There's some people who have pre-existing conditions, who have heart issues, who have some other things that trigger and cause them to die. But when you talk about 84% of these deaths were preventable, what in the world are we doing? And it has such a it's such a horrible effect when it comes to Black women, because now the story is that we are 3 to 4 times more likely to die as a result of childbirth. And there are predictions that that number will eventually be raised to 4 to 5 times more likely. And so the other story I want to tell you, and I'll make this very brief, is that after Charles and the boys, I brought them back to Atlanta, and they lived with me for about the first 4.5 years after Langston was born. And so the way that my house was situated, and I'm a light sleeper, I always left the door open in my bedroom. And Charles, who was Charles V, he was 19 months old when his mother died, and remembered his mother, and he was looking for her. I mean, when we came back the next day from the hospital, and he was all excited because he thought that he was going to get to go to the hospital to see the baby, as he started talking when he was very young. But he was looking for her and calling for her in their condo in LA. And so when we got back to Atlanta, because they had lived with me for a while before they went to California, he had his room, his toys, and he knew where everything was, but he was still looking for her. So now fast forward, he was 3. He just turned 3. And I heard him wake up, right? And so I got up to go in to check on him. And this is what he said to me. I said, sweetie, are you all right? Are you okay? Why are you awake? Blah, blah. And I was, just kind of hugging him. And this is what he said to me. He said, Grandma G, do you have my mommy's cell phone? And I said, no, sweetie, I don't have your mommy's cell phone. He said, Grandma G, I want you to find it. I want you to call heaven. And I want you to tell God that I want my mommy to come home. We got to be in the business, my sisters, of sending mothers home with their precious children. I don't want any children to go through this. I don't want any partner to lose their partner. I don't want any father to stand with an infant and a 19-month in each arm at their mother's funeral. And so that's why we've got to dig in. So some good news is that under the Biden administration, HHS, Department of Health and Human Services, ordered an investigation to be open at Cedars-Sinai. Why is that important? Let me tell you why that's important. Because that's been something that we've been pushing for. And Senator Booker said to me shortly after Kira died, when we were in Washington, I've been in Washington more since Kira passed, particularly those first few years, than I have been all total in my life, knocking on doors, meeting with senators, meeting with House representatives, going to Congress, supporting Charles as he testified, and really working hard to get a maternal health bill passed, which has been the first in history that never been a federal bill passed dealing with this horrific problem of mothers dying in the nation that's the richest nation in the world. And so I cannot tell you, I mean, this is just where I come from, we call it shouting news, is that the department opened up an investigation in Cedars-Sinai. And what Senator Booker told me shortly after Kira died, he said, Judge, things are not going to really change until things get tied to federal funding, right? And so every hospital, I don't care how wealthy the community is, every hospital gets some kind of federal funding. And they opened up this investigation about the disparities among Black and brown women dying at that hospital. And so why is that important? Because if their federal funding gets cut, there's going to be a very different attitude about reporting and attention being paid to these kinds of deaths. And our hope is that that will then cause a domino effect for all hospitals in this nation, all of which rely on federal funding in their things. I know we've got a lot to cover tonight, so I don't want to be too much longer, but I see that as good news. I see the fact that people are conscious of saying we need to go in You need to have a partner advocating for you. If you're in labor for 10 zillion hours, then people have to take shifts. But we did all of that right. We did all of that right. I mean, there was somebody with Kira Charles did not leave her side, right? And then somebody said to me, well, Judge, if they had known that was your daughter-in-law, they wouldn't have let you die. Let her die. And I'm like, the hell with that. We talking, it doesn't matter whose daughter-in-law it is. You know, it's like, we don't want these women to die. And I know that because of who I am, it's created some platforms that we've been able to use to sound the alarm. And for that, I'm grateful. But it shouldn't matter. It should not matter whose daughter you are. We need to send these mothers home. We've got to send them home. And the fact that we're seeing an uptick, and regardless of what your position is about the right to life, right to choose, what we do know and what we anticipate, and we haven't had enough data yet, but when Roe was overturned, it is anticipated that we will see these numbers get even worse. So you've got the double whammy of not having access for women to choose, and then not having the money to go out of state to a state where abortion is not banned. And then complicated, and I'm sure our sister Doc and others will talk about this in our discussion, we saw a young woman die this summer in Georgia, right here in Georgia, because the issue about her miscarriage and what was happening, and they did not intervene quickly enough because they were afraid. Was this going to be deemed an abortion as opposed to medical intervention? And Ambassador Young will not mind me sharing this story because we are very close, and he knows what happened with Kira. We've talked about it, and he's even shared this story publicly, so I will repeat it. Ambassador Andrew Young has a granddaughter who is pregnant. The baby, the fetus was not viable. They would not go in to intervene. She had to carry that baby to term while the fetus was deteriorating, which was putting her life at risk, which was causing her to have this toxic experience. And they were not going to intervene unless it was absolutely clear that she could have died. And so not only did she have to live with the fact that her child was not viable, but she also had to live with the fact that she was at risk because of the toxicity in her system. We have got work to do, and it is not just at the federal level, but it has to be state by state by state, because so much of what is happening in this nation is determined under these, we call it the Gold Dome in Georgia because we have a gold dome at the Capitol, but at the state capital levels. And until there is an awareness, we all know about the studies where they literally did hysterectomies on Black women. Everybody knows about Tuskegee. Not enough people know about those doctors who were performing hysterectomies on Black women without any anesthesia to see what would happen. Like, we have been treated in such inhumane ways. So what are we going to do? Let's talk about what we're going to do. And I know that's going to be the segue to the panel. But what I want to tell you is that giving up is not an option. Throwing up our hands is not an option, even in this climate of these cuts and proposed changes. And with a man who doesn't believe in vaccinations over over the health system and cuts in Medicaid and what are we gonna do? We cannot give up. Last thing I'll tell you is that I was asked to give the convocation address for Founders Day for Clark Atlanta University a few weeks ago. And very emotional for me because my dad is a Clarkite. That's how my parents met at AU one summer in graduate school. And so I grew up on that campus and it's very, very dear to me. So the choir sang the Black National Anthem, which I know backwards and forwards, and I grew up in the church choir, so I think I can sing. And we got to that line, and I'd never heard it quite like this, and I want to leave you with this. It was a line that says, drunk, not let us be drunk with the wine of the world, lest we forget thee. I heard it differently a few weeks ago, and I've heard that hundreds of times in my life. Lest we not be drunk, get drunk with the wine of the world that we forget thee. Let's not get drunk with being depressed about what happened in November. Let's not get drunk with despair and being paralyzed, getting drunk with paralysis. And I said to a group of women a couple of Sundays ago at Women's Day, I said, you know, we can't get drunk with our positions, that we forget the least of these among us. We have so much to do, that there is so much work to do. And so a lot of this is going to be going back to educating doctors, having them sensitized at a different point, that they don't see us as just people who can, you know, drop babies in the field and keep on picking cotton. I mean, those days are over. And that we have to then be our own best advocates for the care that we need. And I know that I need to wrap that. And I'll leave you with one of my grandmama's favorite songs, Walk Together Children, and Don't You Get Weary. You know, run on and see what the end will be. It's a generation of women who are looking to us for leadership. And I don't have time to go into the statistics on the economics, but trust me when I tell you that when a woman dies, it changes the trajectory of that family, economically, socially, and we don't know how long it will take to repair that for generations. And so let's not be discouraged. Let's walk on and keep moving and pressing and coming together. It's like children's Legos. I take your piece with your piece with your piece with my piece, and we are going to rebuild a foundation that people can stand on. And we're going to look back and we're going to know that we did it in a way that will live beyond our lifetimes. And so to you, Madam President, to the committee, to all of you who've joined us tonight, thank you for this privilege. Thank you. I will also tell you, I'm practicing law, and after a lot of prayer now, I am taking on these cases nationwide. I couldn't do it at first because it was too painful emotionally. But the good Lord and I've had several conversations about this, and that's what I'm going to do. Because until there is accountability, I don't know how people will really change.
Wow. Thank you, Judge Hatchett, so much for those words. You have been telling this story for 9 years, and I wrote that down. And I also wrote down while you were talking, sending mothers home. Like that is the core of, I think, what our message is Mothers affect everyone. We talk about fathers a lot with families, but mothers are right there, and that's the heart of our community. So we just really appreciate the opportunity to share this narrative with you and for you to share your story with us. And we've been asking our local mothers in the chapter to share their stories, and it's been already affecting people, and people are already finally understanding why we have to keep having these conversations. So we're going to keep having the conversations, and we have two other dynamic panelists. And obviously, thank you for staying on and joining us.
Oh, of course, of course.
So I'm going to.
Virginia Harris knows whenever anybody in the coalition anywhere calls me, the answer has to be yes. That has to be yes. And I thank you, Sister Hunter, for the leadership on this and the work that you're doing on your committee. This is critical. This is critical. This is no time for us to be backing up.
Absolutely, absolutely. And we don't have time for it tonight, but a lot of our sisters have personal stories, and we've been sharing them. And it's been, people are really, I think, starting to see that how important this is. And it's a today issue, not just Maternal Health Week issue, but a today issue that we have to keep talking about. And I've been sharing this this work with our health chair, Sister Angela Norwood. We've partnered together in putting this event on. So I'm pivoting to her now, and she's going to introduce our other two panelists, and we're going to keep the conversation going. Sister Norwood.
Good evening, and thank you, Judge Hatchett.
Thank you.
Good evening. I'm going to introduce two phenomenal Black sisters in healthcare who are making a difference in maternal health. Ms. Frankie Robinson is a nationally recognized leader in public health and social justice advocacy, known for her unwavering commitment to eliminating health inequities for Black and Brown birthing people. As the founder and president of the Amandia Group, she leads a consulting firm focused on addressing the social, structural, and political determinants of health through policy and advocacy. The firm empowers Black birthing people by working to dismantle the systemic barriers that lead to daily health outcomes. In addition to her consulting work, Frankie is a founder of Black Joy, a doula service dedicated to supporting high-risk clients of color, particularly those with infants in the neonatal intensive care unit, known as the Capital Doula and the Preemie Doula. She provides specialized doula services and training with a focus on positive birth and mental health outcomes for marginalized communities. With 23 years in nonprofit management and 16 years in maternal and child health, Frankie has influenced public health policies across the Southeast United States, advocating for issues such as maternal mortality, social determinants of health, health equity, and paid leave. Her successful coalition building has led to significant strides in improving maternal and infant health outcomes, particularly for people of color. Frankie's advocacy is rooted in her personal and professional experiences, including training in racial justice in birth. She is a graduate of Louisiana State University and holds a Master's of Public Administration from the Southern University. Frankie's work has earned her recognition, including being featured in Ebony Magazine and honored as a under 40 leader by the Greater Baton Rouge Business Report. Most recently, she delivered the keynote at the Dona International Doula Conference and has spoken at prominent events like the American College of Obstetricians and Gynecologists and the Center of Disease Control. Above all, Frankie is a proud wife and mother, deeply motivated by her personal journey and passionate advocate for social change and equity. And our second panelist is Dr. Veronica Lisby Bell, is a board-certified obstetrician and gynecologist and an associate professor of Ochsner Health in New Orleans, Louisiana. She serves as the senior site lead and section head of Women's Services at Ochsner Kenner, as well as the Director of Quality for Women's Services across the Ochsner Health System. Dr. Gillespie Bell is also the Medical Director of Minimally Invasive Center for the Treatment of Uterine Fibroids. She's a recognized expert in managing heavy menstrual bleeding due to fibroids. She is highly skilled in advanced laparoscopic and robotic assisted surgeries, alongside her comprehensive obstetric care. She earned her medical degree from Meharry Medical College, completed her residency at Ochsner Health, and holds a Master of Applied Science in Patient Safety and Healthcare Quality from Johns Hopkins Bloomberg School of Public Health. Additionally, she is certified in diversity and inclusion by Cornell University. Dr. Gillespie Bell is a passionate advocate for maternal health and has worked extensively to address maternal health disparities in Louisiana. As medical director of the Louisiana Perinatal Quality Collaborative and the Pregnancy Associated Mortality Review for the Louisiana Department of Health Care, her leadership has taken her to a national platform. She has testified before Congress, led briefings, and spoken at the White House Maternal Health Day to advocate for policy improvements for maternal care. Her clinical and advocacy efforts has garnered national recognition. Dr. Gillespie Bell has been featured in major outlets such as USA Today, the New York Times, and appeared as a speaker at events like the Essence Festival, Good Morning America, and the 1619 Project docuseries. Welcome, ladies. I'm going to start.
Much. Thank y'all for having us here today.
Love the bio. I am going to start off with you, Dr. Gillespie. As the medical director for Pregnancy Associated Mortality Review for Louisiana Department of Health, what is the scope of problem concerning Black maternal health, and is it improving?
So I'm actually going to take it from big picture to little picture, and Judge Hatchett has already started talking about this. So as Black women, we really are getting knocked down twofold. So the United States, one of the highest income countries, we have the worst maternal outcomes, and our outcomes, as she's already mentioned, have been getting worse. Now, we did see an improvement in outcomes from 2021 to 2022, and then again in 22 to 23. Part of that's because the rates were so high in 21 because of the number of women that were dying from COVID-19 and also just not being able to get into care. Because when you look at 23, the rate is still higher than what it was in 2018. So we're in a country that has the worst maternal outcomes of any high income country. Then when you look at maternal outcomes for Black women, as is mentioned, our rates are 4 times higher. So in fact, from 2022 to 2023 in the United States, maternal mortality rates, like I said, they did get better, but they got better for every single race except for Black women. Our rates actually got worse. So when we look at that, now taking it down to Louisiana, we see the same thing. So our last report on maternal mortality was in 2020. We had 15 pregnancy-related deaths, meaning that women died from a death that was related to the pregnancy, died from something that was related to the pregnancy. Of those 15 pregnancy-related deaths, 13 were among Black women. So we have the same disparities in Louisiana as we have across the entire country. And until we as a country deal with what is driving the disparities, and it will always be implicit bias and structural racism, until we deal with those two things, even if outcomes start to improve, we will always have that disparity. And there are a lot of things that are in place that are improving the outcomes. We have our state perinatal quality collaboratives like the California Maternal Quality Collaborative, and we are seeing improvement in Louisiana with severe maternal morbidity from hemorrhage and severe maternal morbidity from hypertension. But if we're not dealing with those two underlying things, then we will continue to have this disparity gap.
Thank you. Can you tell us how long after the end of pregnancy can a death still be classified as pregnancy related? And what are the top causes of death and its contributing factors?
So that's a very important thing to understand and to think about. So the maternal mortality review committees in every state, we review the deaths for someone that was pregnant at the time, that died at the time of pregnancy up to 1 year of the end of pregnancy. What's important about that is because when we look at it, we're realizing the majority of deaths are not happening at the hospital. They're happening after delivery, up to 1 year postpartum, with the majority of those happening in the first 6 weeks. So let's think about what our healthcare system looks like. You deliver your baby, and when do you see another healthcare provider? Not until 6 weeks. And clearly there's a lot of things happening between delivery and 6 weeks. That's when the majority of deaths are happening. We are also the only high-income country that does not guarantee at least one postpartum visit in your home in that postpartum time. The only high-income country. So, when we think about, again, that definition of what deaths is and when we're looking at it, when we look at that longer time period, then we're really able to get insight as to what is happening, what's causing those deaths. When we look at across 38 maternal mortality review committees, the leading cause is actually mental health conditions, which is a combination of suicide and substance use disorder. When we look specifically for Black women, though, it's cardiovascular conditions, cardiomyopathy. So a lot for us to think about in the way our healthcare system is designed. And so for me, as I think about improving our outcomes, there is a framework that I've created, and it's a Venn diagram. If y'all remember from school what a Venn diagram looks like, that means we have overlapping circles. So we got to if we can't take care of one without taking care of the other ones. And it really is addressing our social determinants of health, because 80% of clinical outcomes are due to social factors. It's improving clinical quality of care, and that's where our perinatal quality collaboratives come in, working with our birthing facilities to implement those evidence-based practices. And it's improving our systems of care. Judge Hatchett already talked about one of the things that's a threat right now. I think one of the reasons we're starting to see the trend of maternal mortality possibly getting better is because most states have extended Medicaid to 1 year postpartum. We've already said the majority of deaths are happening after delivery. And so we're at a time now where that is at threat, where women may not have coverage. And Judge Hatchett correctly said 41% of births in the United States are covered by Medicaid. Well, it's 62% of births in Louisiana. So that's 62% of our patients that may not be able to get back into care for that time that we've already said is so, so, so important. And I could go on and on and on, but I'm gonna stop.
Okay. We know the scope of the problems here in the U.S. Affecting the numbers with Black maternal deaths are racial and ethnic disparities, from lack of education to access of resources. Speaking of access of resources, can you explain and give examples of maternal care deserts and its effects on our population?
Yes, a couple things around that. So yes, the resources, especially our social drivers of health, that is a huge, huge, huge contributor to maternal mortality, regardless of race. So again, as I mentioned before, 80% of clinical outcomes are due to social factors, due to access to healthcare, due to access to transportation, access to childcare, economic stability. Of all of the social drivers of health, I think economic stability is the one that is the strongest predictor of your health outcome. So we do have that in play. But I don't want to ignore the fact that when we look at the data, that a Black woman with a college degree is twice as likely as a white woman with an 8th grade education to experience a pregnancy-related death. So it's not just about social factors. And that's why I say for our disparities, it's always going to boil down to implicit bias and structural racism. Structural racism affects the social determinants of health, but implicit bias affects how we have health care disparities, the differences in how we are inadequately treated when we are in the healthcare system. So I just want to make sure that
I have to chime in too, Doctor, and I'm so glad you made that point, because they are so quick to say that because Black women are all, they want to paint us as all poor, that we didn't get the right medical attention. But educated women, I'm so glad you said that. Educated Black women are still dying at alarming rates, far exceeding a woman with an 8th grade education. And so they can't just stereotype us in this conversation. So I'm sorry, I just had to jump in on that one, because I am sick of that. I am sick of that them saying, well, broad brush, they're dying because they're not doing what they're supposed to do.
100%.
Okay,
And
I'm
I
gonna be
hear
quiet.
that.
I'm sorry, I had to jump in on that. I'll be quiet.
It's a panel. I think it's great. But no, it's something that we have to talk about. And I hear that as I go across the country and speaking about this, is there is this belief that we're sicker, we're overweight, or we're more overweight, or we just are non-compliant, which is a word I wish would be removed from everybody's vocabulary, without understanding the historical, systemic, and bias, and the ways that Black women have been described through, we don't have time for the history lesson, but through the different archetypes of history. And we talk about it some in the 1619 Project, but all of that has then impacted how we as healthcare providers see Black women. The angry Black woman, that comes from a character named Sapphire from Andy and Amos back in the 30s and 40s. So that is what we see when we hear Black women complain. Then we're like, oh, that's just an angry Black woman. And so that's why Black women's voices are largely ignored when we come into the healthcare space. And so we hear stories of Serena Williams having to beg to get a CT scan because her voice got unheard. And it doesn't matter if you're Serena Williams. It happened to me when I was pregnant. It does, none of those things matter. And I think that that's so important for everybody to understand, all of us as women in the healthcare space, but those that have the ability to make decisions, that lead policy. It's that it's not just poor Black women that are dying. It's all Black women. It's all Black women. And I'm sorry, Angela, I went on a tangent and I forgot what your question was.
We're talking about giving some examples of maternity care deserts, far as going into, like, they might not have maternal health close by. They have to go to the ER
Yes.
to follow up.
So that's another confounding problem. So we have our maternity care deserts. So, I think I'm frozen. So we have our maternity care desert. So a desert is a place that has no OBGYN, no midwife, no family physician that's providing obstetric services, or birthing hospital for 10,000 births. So for the United States, about 35% of our country is considered a maternity care desert. In Louisiana, we're at 26.6%. And so obviously, if you don't have access to care, then that your outcomes are going to be worse. And there are women that have to drive in Louisiana up to 60 minutes to get to a birthing facility. Now, thinking about that, this is a problem that I expect to get worse because we're seeing Medicaid cuts. We're talking about it. And so a lot of hospitals are closing because they're not getting the reimbursement to be able to keep their doors open for obstetric services. There was an article that was published in JAMA about a year ago that showed that in rural locations where those birthing facilities are closing, it's mainly because of decreased reimbursement from Medicaid. So these deserts, I think, are going to get worse. We are trying to combat that, I will say, in several states, but in Louisiana, we're trying to combat that through the Louisiana Perinatal Quality Collaborative, the LAPQC. We've created an initiative of obstetric readiness in emergency departments where we're trying to help our emergency departments be better prepared, because that is the other issue. Whether you're pregnant or in the postpartum period, especially if you're in a desert, where are you going to go? You're going to go to the emergency room. Well, those emergency room providers, they don't understand or they don't know what an obstetric emergency is. If a woman comes in and her blood pressure is 150 over 100, that's not alarming to an emergency room provider. If that patient just had a baby, that's alarming to me because I know that's a patient that may be getting ready to seize, or she may be getting ready to have a stroke. And so that education piece needs to be in there for the emergency department, the emergency room providers, to understand that that is what an obstetric emergency is, how to recognize it, how to respond quickly. And so that's some of the work that we're doing to try to mitigate the fact that there are going to be more hospital closures and there are going to be more deserts.
Thank you. We have Miss Frankie Robertson on our panel, who is a doula. How instrumental are doulas or midwives in decreasing the Black maternal deaths? And you can start off with that on the doctor's perspective. And Sister Frankie, you can bounce off of that.
It is hugely important. If anybody has ever heard me speak, if you have ever seen my videos, I am a huge, huge, huge supporter of both midwives and doulas. Again, I'm not just speaking about other countries. When you look at other high income countries that have better outcomes, they have more midwives and less OBs. And I'm saying this because I've seen it being in Australia. The midwives and the obstetricians work collaboratively together to take care of patients. We're in our country, we are going to be short 5,000 OBGYNs by 2030. So in 5 years, we will be short 5,000 OBGYNs. So if we're going to be short, then that means we already are doing bad. And we're not going to have enough obstetricians to take care of the patients that need that care. So we have to develop different systems of care. I'm happy to take care of any patient that walks in the door, but it makes a lot more sense for that patient that is low risk, for all intents and purposes, is going to have a vaginal delivery, she be able to see the midwife. And so now I'm available for that patient that has hypertension, diabetes, and this is her third C-section. We're not doing risk appropriate care or risk management to make sure low risk patients can get to midwives and high risk patients can get to the doctors. And so what's happening is there's just not enough space for all patients to come in to see the doctor because there's not enough of us. And so we have to think about that care differently. And for doulas, I think that's hugely important, again, in being in the birth space. You just need somebody to advocate for you. I think doulas are amazing for being able to understand the OB world. They're able to understand that their individual patient. They're able to understand the social factors that patient has. I love postpartum doulas. They're just, I think, so instrumental, especially in Black maternal health, of just having that other person to advocate for you on your behalf.
So Angela, I think, and Dr. Gillespie Bell summed it up really on both sides, but as a mom of two and also as a doula, it's so important that when we look at the models of care with OBGYNs and then the midwifery model of care, there are some major differences. The specific role of the doula is beneficial to both the OBGYN and the midwife. Looking at the obstetrics model of care, it's very busy. It's very fast paced. There's a limited amount of time that the doctor is able to truly, truly give their patients beyond the actual appointment itself. Now, some doctors, like Dr. Gillespie Bell, of course, amazing bedside manner, they're going to take their time as much as they can. Like any profession, that's not like the story for everyone. So, having given birth twice and then also being the go-to person for many friends and then, of course, my clients, people leave the doctor's appointments with more questions sometimes than what they came with. I know I would go in with my Apple Notes and go to the doctor, and then I'm like, wait. And my doctor too has this bedside manner that she'll just wait forever with you. But then I still had questions. There's an educational piece of this that I think is very golden in terms of doulas being able to slow it down, especially the doulas that attend the prenatal appointments, such as I do. You're able to go there with your client and you're able to digest all this information. You're able to go connect with them afterwards, debrief, turn some of that medical jargon into everyday terminology. And then you're that constant. One of the things that we can't forget here that is really a winner for that client is that some insurance plans, especially our moms who are insured by Medicaid, that continuity of care is just not there. You can see a different doctor sometimes every visit, and then you've got a brand new person there when you go to deliver. I'm a privately insured mom, and both times my doctor wasn't on call when it was time for me to deliver. And the first time that was very jarring to me because, it's a very personal event, right? And I have a relationship with my OB, and all of a sudden, it was Memorial Day weekend, and I met her colleague for the first time. When I had my C-section, my doctor actually came on call because we knew that it was a high risk situation, a preterm birth, and she wanted to be there for me as well. If I'd had a doula in both of these pregnancies, I think that my outcomes, particularly with my last pregnancy, would have been different. It would have been different with having someone there to help me support my needs with my stress level, which was abnormal, support me in managing and understanding what was happening and helping to regulate my fears when I learned that I had a potentially life-threatening complication that could happen. I had a placenta previa. So if I'd had a doula from the time that I got that particularly jarring news during my anatomy scan, I could have just had someone there with me to let me know it's okay medically until I saw my OBGYN. So I'll close and say this. We have to look at each of these three medical experts as team members. There's not one that can operate at its best without the other. The doula complements the OBGYN and the midwife. And when that birthing person has the full advantages of having all of those gaps closed, it just, studies have shown that it can and does produce better birth outcomes.
Awesome. Ms. Robertson, just one more follow-up question. And Dr. Gillespie Bell already talked about, and I think Judge Hatchett mentioned this as well, changes in federal legislation now allowing postpartum care to go out into 1 year after the delivery. Why is that so important? We've heard some comments about it, but it'd be great if you fill in more gaps, especially for moms and the attendees that are on the line who think that once they've had the baby that they're good to go. Why is that so much more now important? And even more so, those warning signs that can be showing up after the baby is delivered.
That is such a great question. I think a few things. One, I just want to appeal to everyone on this call and everyone within your networks is that we truly have to unlearn what we think the postpartum period is. When the mom has the baby, it is not the end, it's truly the beginning, right? Just from even the best case scenarios, a new way of life, navigating life with more than one child, navigating a life after a loss and having a rainbow baby, entering into parenthood for the first time. There's all sorts of life changes that occur. We don't have adequate social supports in our country where there's states like ours and many others that don't even provide adequate paid leave for moms after they've had a baby. You literally at the worst time potentially of your life where you need financial security the most, you're having to choose between healing, having adequate time for your child, getting into a successful breastfeeding journey, or just navigating this new life versus keeping your lights on or a roof over your head. The way that we treat moms in the postpartum period is inhumane. And sometimes the way that we as moms have internalized what we're supposed to do afterwards, whether it's bounce back, whether it's business as usual, we cannot fall prey to those unrealistic demands of us, right? And for some of us, it's easier than others to say, I'll take a stand. And many of us, we truly can't take a stand because we're being used and abused. So I think that looking at the timing of pregnancy deaths that Dr. Gillespie Bell shared earlier, we know that it's in the 42 days to up to a year. Moms are still healing physically, but not just physically, mentally. There's a lot of warning signs that you have to look out for. Two in particular are those that are related to hypertension. Some moms don't understand that you can still have preeclampsia after you have your baby, and a lot of the readmits in the hospital are due to dysregulated blood pressure disorders. But then there's also the presenting of maternal mental health disorders that also are contributing to death after pregnancy, where moms need that support to address mental health disorders, but then also the correlation between substance use disorder and the lack of available resources for moms to get the help that we need after giving birth.
Thank you. I'm gonna ask one more question. Recent Louisiana law required insurance policy to cover doula services. What can we do to improve maternal health outcomes, and what is covered underneath your services?
Sure. So a few years ago, State Representative Matthew Willard, a true champion for maternal health in our state, authored a bill that required private insurance companies to cover doula support services, um, oh gosh, up to $1,500 per pregnancy per year. And that is something that is really important for communities to know, that if you're privately insured in this state, you likely have access to doula support services. And that actually just went into effect about 2 years ago. Also, recently, the managed care organizations in our state, 5 of 6, have been providing Medicaid covered doula support services through their in lieu of services policy. So chances are moms who are insured by Medicaid also have close access to doula services. So it really boils down to making sure that our insured moms take a look at their coverage, whether it's Medicaid or private insurance, and see what they have access to, because having a doula has been proven to do many things, but 2 key things that are really very problematic and occurring more frequently in our state compared to other states are cesarean sections that are non-medically necessary, and then also preterm birth rates. I'm a mom of a preterm baby born 3 months early. So we are, as Black women, are at higher risk for preterm births. And unfortunately, the data also shows us that we are the highest race of women who are being given C-sections as well.
What is that website I can find a doula? Can you give us that?
Yeah, I'll double check in the chat and put that in the chat, but it is sistermidwife.com, and I'll put the link to the Sister Midwife and Baby Dove Find a Doula directory. You could Google that. You can Google it, it'll come up, but I'll link it in the chat for everyone. And you can go in, not only find a doula, but you can find a Black doula. This site is specifically designed to find a Black doula, but there's also a state website that's also collecting information of doulas and other community healthcare workers who are available.
Awesome. Now shifting back to you, Hatchett, and I've been waiting to ask you this question. We all know, we have all seen what's been happening with the new administration. And we have seen the rollback of diversity, equity, and inclusion policies. And you have talked about it, Dr. Gillespie Bell have talked about it, disparity, implicit bias. How do we approach it now? If we're in the hospital, we're receiving services, and we're concerned that we're being treated differently, what do we do? Who do we ask for? How do we approach still advocating for ourselves, speaking up for ourselves, when the very thing that we think will address the issue, which is being, training and all of those things for healthcare professionals to be aware of the bias, if we can't really talk about the bias, how do we approach this issue now?
I think we still talk about the bias, frankly. I know that there's all this effort to just erase DEI. And the irony of all of this, frankly, is that DEI, the biggest beneficiaries of those policies were white women. And I said recently that they want to exclude us from the table when we Black people built the table. This economy was so built on our sacrifices and slavery and all the things of the inequities. But I would say that in any situation, it is important to know the chain of authority in that hospital. It is very important before you go in that hospital to know that chain of authority. And so that if you're and whoever's advocating for you feel that you're not getting the kind of treatment that you should get, then you've got to sound that alarm, and you've got to keep escalating it up and up and up and up. Is that going to guarantee outcomes that are appropriate? I can't tell you that's going to guarantee it. But I do know that we need to be sensitized to that and understand that we have to keep raising the issues. And we will not be silenced because they are going to, or in the process of dismantling things like DEI, our history, the Smithsonian. I mean, you know, it just goes on. I was watching something today about these murals that were just literally bulldozed, like the jackhammers on the street in Black Lives Matter. But those are symbols in a sense. And what I have to keep reminding people is that, yeah, I didn't want the street to be jackhammered. I did not want the jack, but I don't want to get off the main thing of us being in the business of trying to save lives. And so we've got to pick our fights. And I'm not saying that we should roll over and play dead. I mean, if you know anything about me, that is not who I am. I've never been that. But we've got to be very strategic in how we fight these fights. And some of this is going to take a longer term of the more doctors. I'm concerned, as our sister doctors talked about, 5,000 less OBs. My God, what does that mean? And in Georgia, particularly, and I'm sure other states where there are abortion bans, people are saying they don't want to come and do their residency here. They don't want to come and practice here. And what does that mean? I mean, maybe you just say, okay, I'm going to, not to downgrade dermatologists, but maybe I'm just going to go and do something that I'm not going to be at risk of prosecuting, you know? And Evelyn was my cousin, who was the Black doctor decades ago who was prosecuted for performing an abortion in Boston. And so this has been something that our family has been living with for decades, of how do we deal with the discrimination? How do we deal with outcomes? And I don't have an answer for you, Sister Hunter, but I do know that I don't care what they're saying about DEI. We have a responsibility as advocates for our family members, for people we love, for people in our communities, to keep sounding that alarm. And the numbers speak for themselves. I mean, it's not like we're making this up. This is something that we imagine. We know the disparities. We can document the disparities. This is sound proof of the disparities. And so don't tell me that it's not raining when it's storming.
Yep. Wow. Well, we are getting close, so I'd like to yield to Ms. Robertson and Dr. Gillespie Bell for closing remarks for the panel, and then we're going to turn it over to Sister Angela and take some questions from the chat. So, Sister Robertson, I'll yield to you first for some closing remarks, and then Dr. Gillespie Bell.
Thank you, Ms. Hunter. I absolutely echo everything that Judge Hatchett just said. Censorship is not new. When we look at the days of enslavement of Africans, not allowing us or threatening our lives, or in some instances killing us if we read, making rules and laws that we couldn't congregate, together for fear of planning an uprising. Now, in the age of information technology, we have so much information at our disposal. We have uncovered truths about our history that many of us did not know into adulthood. We have internet tools at our disposal where we're sharing them rampantly, and that's problematic. So now there is a direct assault on Blackness, lots of anti-Blackness, to erase what is there for future generations to come, to ban us and censor us, to say that we can't talk about diversity, equity, and inclusion. I asked this question. We are really just trying to survive. These aren't jobs for us. We're talking about not only our lives and our livelihood, our right to live and survive and thrive, but for our children, those of us who have children, those of us who have a deeper understanding and commitment to community. What do we have to lose? So there's no censoring us. Yes, we're going to say Black, we're going to say diversity, we're going to say equity and inclusion, we're going to talk about structural and systemic racism. This is not a game for us. This is our right to survive and dismantle or tear down these systems of inequity that continue to just disrespect us. And all we really wanted to do was just be left alone and to thrive. So my closing comments would be stand up, fight back, engage in policy, work to dismantle these systems, tear them down from the ground up, and be unapologetic about it. Again, these are our lives. These aren't sound bites, speaking points, or jobs. It's our right. It's life or death for us.
And I'll be very, very brief. The biggest thing when I'm in forums like this is just to remind everybody to vote. We are where we are because of public policy. And I'm not just talking about today, but public policy is what causes the difference in the social drivers of health and the lack of resources. And so much that has happened throughout history is unfolding in front of our eyes every day. And to your point, Frankie, I think about my son and what type of country is this going to be when he's my age. And so we all have that ability to vote. And I'm not just talking about the presidential election. I'm talking about local level voting. I'm talking about state legislative, like we all have to go out and we have to vote. And I think the other thing that I would say, just to balance the conversation, I have so many young Black women that come up to me now. I was in DC, I remember doing a congressional briefing, and one of the staffers came up and she said, well, my friends and I have just decided we're just not going to have a baby because we're afraid we're going to die in childbirth. And we, not only are we disproportionately dying, but now we're robbing our young women of the joy of motherhood because they're scared to give birth. And so these numbers are horrible, and we need to make sure that this that we do not lose another life, because many of these deaths are preventable. But we also need to celebrate Black joy. I have the pleasure of attending so many joyful Black deliveries. I've talked about just some that stand out in my mind, where one of my patients, I think, listened to the entire Isley Brothers soundtrack, singing songs in between pushing, and just so many joyful Black births. And so I just want to make sure that those that are out there that are wanting to be mothers, don't let fear rob you of what has been one of the most joyful things for me, being a mom. Just know that you need your system, you need your support. So OB that you can trust, a midwife, a doula, and your support system outside of the birth space when you go into your home and you go into your community. But let's not forget about Black joy.
Absolutely. Thank you so much, Sister Angela.
Thank you, Judge Hatchett and Dr. Gillespie and Ms. Robertson, for your insight and valuable information on Black maternal health. We would like to open the panel for a short Q&A. So I have a question in the chat. How can we ensure that Black women are fully informed and empowered to make decisions about labor induction, especially when it's not medically necessary? And what can we do? What can be done to prevent pressure or bias from influencing those decisions? I guess she's asking C-section versus vaginal birth, the pressure. I guess that's a Dr. Gillespie question.
I think just induction in general, because definitely different providers practice in different ways. So whatever provider you're seeing at any point in the pregnancy, whatever decisions that are made about how your care is going should be done in a shared way. Like when I see patients, I tell them the risks, the benefits, the alternatives, we make a decision together. Plenty of times patients make decisions that are not the decisions I would make and not always the decisions I would recommend. But as long as it's safe for them, safe for the baby, I support that decision. So if you are under the care of a provider who is not allowing you to have say in your care, you need to see another provider. And so, in terms of with inductions, there's data that shows inductions in certain situations that reduces the risk of C-sections. And so it's just a matter, I think, again, of having that provider that you can talk to that has the data. If you have a midwife, if you have a doula as part of your care, to also have them in the conversation to be able to give you some of that information. Again, inductions are not always bad in some situations, and looking at the biggest trial for inductions, those women that were induced, their C-section rate was actually lower than those that went on into spontaneous labor. But that's just one part of the story. It's also the management during the labor process. But again, the biggest take-home message is you should have a provider that is not pushing you towards one decision or another, that you are able to discuss and make that decision together.
Thank you.
I love that in the chat, brained. That's right. Benefits, risks, alternatives.
Judge Hatchett, you had mentioned an article by JAMA. Could you give the link or the title of the JAMA article that you were referring to? I cannot hear you. You're muted. You're still on mute.
I apologize. I have got to find that link to that article. I'm so sorry.
When you find it, just email it to me and I will see.
I'm so embarrassed I don't have it. I'm actually standing here scrolling it because it came up in an article this week and I had it and I saved it. And maybe I'm going to find it before we finish, but I will. I'll definitely get it to you. And my apologies on that.
What type of info should be included in the care birth plan, and who should it be shared with? That's a medical question. I guess Ms. Frankie and Dr. Gillespie.
Sure. So if you have a doula, clearly you want to share that birthing plan with your doula, because your doula is going to be your advocate that will work their best to make sure that that birthing plan is adhered to as much as it's medically possible. In many instances, with your doula, you'll sit down and prepare your birth plan together, right? And then, of course, the birth plan is shared with your medical provider, whether it's your midwife or it's your OBGYN. And then once you are at your actual birth, it's always best practice for your doula to have copies with them to provide that to the medical team. So your nurses will make sure that they get it. It'll be shared if shifts change, and anyone who's coming in contact with that birthing person, because those plans can get very, very specific, right? So basically everybody who's coming in contact with a person that's giving birth should have that plan, including the family members too, that are allowed to be a part of that birth.
And Judge Hatchett, Dr. Gillespie put the article in the chat for everyone. She found the article.
Thank you. My technical skills aren't that great. I'm sitting here trying to figure it on the phone while we're talking on here. And thank you so much for doing that.
Somebody shared it with me earlier today, so it was easy to find.
Oh, perfect. Because, I had cut and paste little quotes out of it, but I'm like, I don't have the link to the thing. Good gracious. Thank you.
One more question. Dr. Gillespie, after 33 weeks, can you change a provider after 33 weeks or anytime during the pregnancy?
That's a tricky question. It depends on the provider. There are some providers that will not accept patients if they're transferring in the third trimester. And so it can be a little bit harder to find a provider, but that doesn't mean it's impossible. And that's a provider preference. There's no rule or law or insurance mandate that says you cannot transfer after 33 weeks.
And this question is across the board. What is the best way to start meeting with OB medical professionals about Black maternal health? How can we start this conversation in the community more and get everything started?
Well, I think that there's been a lot of great conversations. I see the conversations happening nationally, thankfully, with technology, seeing the Zoom conversations that are happening, but there's also in-person conversations that are happening. We just need to keep those conversations coming in the age that we talked about, where we have a direct assault on conversations about racism and disparity. We just have to continue to move forward. I can say here in Louisiana, there's some really strong conversations that are happening between OBs, between midwives, between birth workers, and in the community. So conversations like this are a great example, and we just have to continue them. But they are happening, and they are happening in Louisiana, but we have to make sure that they continue.
And I think I'm sorry, go
Go ahead.
ahead. I was
No,
gonna say, I
please.
think it's so important that organizations like the National Coalition of Black Women, our sororities, other community-based organizations continue to have the conversations and continue to advocate for the data. So the work that I do for the Maternal Mortality Review Committee and the Perinatal Quality Collaborative, those are both funded by the CDC. The data that we just put in the report, that we just put in the chat, that's all from the CDC. So we know who is leading that now. So I don't know what that data is gonna look like a year from now. I don't know if they're even going to look at if they're gonna disaggregate the data by race a year from now. Certainly, because of the executive orders, there are conversations that we can't have. There are buzzwords that we can't have. There's research that I'm doing that I'm concerned we're going to lose the grant because it has the buzzwords. And so I do think it is going to be on organizations that do not necessarily have their funding completely tied to federal avenues to continue the conversations and continue advocating for the numbers and advocating for the work.
I ditto to that. I would just also add that in addition to more of the grassroots work, that we also make sure that we're having these conversations with our legislators who are going to hear it. I know that there are, for instance, I just keynoted the Black Legislative Caucus in Georgia for their annual Black tie dinner the other night. And it occurred to me that these conversations need to be happening at these different caucus meetings of legislatures around the country, not just the federal level and not just Black legislators, but women and people and men who really understand how this is important, and build these kind of coalitions.
Thank you. I am going to yield my time to Sister Nina.
Oh, I like that. Okay, sisters, panelists, obviously, Judge Hatchett, Ms. Robertson, Dr. Gillespie Bell, thank you so much. We are now at the point where we would like you, everyone, to complete a survey. So our sisters with technology, could you please put the QR code on the screen and or the link to the survey in the chat. As you know, we are advocacy organization. This is a joint effort between health and public policy, and we use data. We use statistics, and we measure outcomes. So we ask everyone to please complete the survey and answer the specific questions. And it's a short survey, only 6 questions, but we ask that you would please go ahead and participate at this time. Am I seeing the
QR code is up.
okay. And in the chat. I don't see in the chat. I'm sure it will be coming momentarily. Additionally, you will have an opportunity to fill out the survey as this webinar ends. You will get a separate email, but obviously we want you to do it now because this is the most likely time that you will do it. With that, I'm going to yield to our first Vice President, Dinesh Piper, for closing remarks.
Good evening, everyone. On behalf of the Metropolitan Baton Rouge Chapter of the National Coalition of 100 Black Women, we thank you for joining us for this deeply moving and impactful conversation on Black maternal health. To our keynote speaker, the Honorable Judge Glenda Hatchett, your words have empowered and challenged us all. You reminded us that giving up is not an option, and that we can't get drunk with despair, depression, or with our positions that we forget the least of these among us. Also, a generation of women are looking to us for leadership. Thank you for your courage and for calling us higher. To our brilliant panelists, Dr. Veronica Gillespie-Bell and Ms. Frankie Robertson, your expertise and advocacy are beacons of hope and tools for change. We are grateful for your contributions to this vital discussion. We extend a heartfelt appreciation, at least I do, to our Maternal Health Subcommittee and recognize the phenomenal leadership of the Health Committee Chair, Angela Norwood, and our Public Policy Co-Chair, Sister Nina Hunter. Your tireless efforts and commitment to this cause made tonight possible. This event was proudly brought to you by the Metropolitan Baton Rouge Chapter, an organization rooted in advocacy, empowerment, and justice for Black women and girls. As we leave tonight inspired and informed, let us also be activated. Our advocacy doesn't stop here. It extends to the voting polls, where we have the power to eradicate harmful laws and enact policies that protect the health and dignity of Black mothers. Use your voice, use your vote, be the change. Let's walk on together, determined, united, and committed to sending mothers home. Thank you and good night.